Well, I hope you enjoyed seeing a new face on Talking Points. Dr. Serena was outstanding, as I promised. We are bringing you another new face to join me on the most popular segment of the show, the Wheel of Wounds. And joining me today is the lovely Katie Urbanek. Katie, please come on out. How are you, Katie?
Hi, I'm doing well, thank you.
Katie is the executive director of the American Board of Wound Healing, and we decided to introduce her to you and allow her to spin the wheel today. Katie, do you feel up to it?
I do.
Fabulous.
Yes.
Now, I understand that you're going to be back a little later in the show to share some updates with us regarding the American Board of Wound Healing. I understand you've had some recent certifications.
Yes, we do, and I will explain about that later.
Are you feeling strong?
Very strong. I'm ready to go.
All right. Well, why don't you give our wheel a spin?
Okay.
And around we go. That wheel is spinning. Pretty good spin there. My goodness. Where are we going to land? Let's see. You have picked soft tissue radionecrosis. Did you have any idea it was going to land on soft tissue radionecrosis?
I didn't. I'm very excited about this.
Well, we're going to go back to our guest of honor, Dr. Tom Serena, and he's going to talk to you about the management of soft tissue radionecrosis injuries. Katie, thank you so much for joining us. Maybe we can have you back on another show.
Thank you. Sounds great.
Stick with us.
Now we're going to discuss soft tissue radionecrosis, as we saw from the wound wheel. You know, it's estimated that 1.2 million new cases of invasive cancers are diagnosed every year. And this data comes from 2002. About 50% of them will receive radiation therapy, and about 5% of those treated patients will develop complications related to the radiation therapy. There are three basic phases of radiation injury: acute, subacute, and delayed. When we look at acute injury, it's just due to direct cellular toxicity. It's mediated by free radicals, it tends to be self-limited, and our radiation oncologists tend to treat it very successfully in a symptomatic fashion. Radiation injury that is subacute typically is manifest as only a few organ systems. The radiation pneumonitis is kind of the classic example. It usually comes on about 2 to 3 months after the patient has received radiation therapy, again, tends to be self-limited, and can evolve to delayed injuries, but typically it is self-limited. Now, looking at delayed radiation therapy, this is where, as a hyperbaric physician, you're going to be focusing. It's the onset after a latent period, typically 6 months to years and years, and I saw a patient who had had radiation therapy 70 years before she developed a soft tissue injury. It's precipitated by some insult to the tissue. So patients, for example, who may have a sacral wound, and it may be thought to be a pressure ulcer, and as it turns out they had a radiation in the remote past. You need to be careful to ask those kinds of questions. When you look at it histologically, the hallmark sign, endarteritis. It is a progressive microvascular disease. It is classically seen histologically as being hypocellular, so there's no cells infiltrating to heal the wound. Hypoxic, in other words, there's just simply not enough oxygen there, and that's a result of it also being hypovascular. So when you look at it under a microscope, you don't see a lot of blood vessels or capillaries. Also, you see a lot of tissue fibrosis in radiated injured tissues. So let's talk about the effects of radiation therapy. What you see typically is tissue cell death. When you look at the vasculature, you see sclerosis, and if it's bone, you're going to see aseptic necrosis. Now, what causes this? What is the process? It's caused by fibrogenic cytokines that are a result of the radiation. They're present early on, starts in the acute phase, but over time, they cause a progressive destruction of the vasculature, and the wound becomes hypoxic and acellular. The risk is dose dependent, so it's important when you're evaluating your patients to know the dose that they received. The radiation effect in tissue worsens with time, and it's due to progressive obliterative endarteritis, which results in hypocellular tissues, hypovascular, and the resulting hypoxic tissue. And if you're trying to get one of these wounds to heal, very, very difficult. They simply just do not heal. Now here's a typical patient. you can see just clearly that he's already had radiation therapy, and it's extensive, and it's been quite some time. And he now has an injury right around his stoma there, and this is just not going to heal without an aggressive multimodality approach, which is going to include hyperbaric oxygen. It's just a close-up view. So the management, you're going to use good wound care, good basic wound care. Antibiotics may be necessary. Surgical intervention may also be necessary, and then this may be as simple as debridement or as complex as a flap that will needed to cover the tissue. Typically, if we're going to do a flap, we'll do hyperbaric oxygen before and after the flap. And the hallmark procedure for the treatment of radiation injury in the soft tissues is hyperbaric oxygen. It really is the standard of care, and the literature supports that. Thank you very much, and I'm glad I got to play on the wound wheel.